Ethical Perspectives on the News is produced by the Interreligious Council of Linn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Welcome to Ethical Perspectives on the News. I'm Bob Rush, and today we have gathered an outstanding panel of experts in an area that is, should we say, murky and not well known. We do know that Americans spend more than any other place in the world, the most on prescription medication. Some 12% of our federal budget consists of Medicare spending. Part of this world of why is it so expensive is a dark, fuzzy, foggy area. We're going to talk today with our experts about what's called pharmacy benefit managers, PBMs. They're the middleman in this whole arena of drug purchasing, drug acquisition, sale, manufacture to pharmacies. You're going to hear some discussion about DIRs, D-I-R, direct and indirect remuneration to pharmacies. You may hear about something called clawback, which is a term that our experts will discuss. It involves the payor, or in this many situations, the pharmacy benefit manager, to go back to the pharmacy and many months, oftentimes from the sale of the medication, and claw back some of what could have been paid, should have been paid. So we'll hear different perspectives on that tonight. Our panelists, we're fortunate to have with us Senator Charles Grassley, Dr. Chris Peters, a practicing physician, and Brett Barker, who is with the Iowa Pharmacy Association. Gentlemen, welcome. We're delighted to have you.
Thank you.
Let's start first with Brett. Would you talk a little bit about what is a pharmacy benefit manager, this PBM?
Sure, and like you mentioned, pharmacy benefits managers are the middlemen that process prescription claims. The big three PBMs touch almost 90% of prescription claims in the United States. And what started as a way to electronically do real-time claims transmission between pharmacies and payers, which is what it started with, done over fax modem many decades ago, has now morphed into companies that are vertically integrated. There are 3 Fortune 15 companies, 3 of the largest companies in America. And now they control a lot more than just prescription claims. They have a lot of power within the industry over manufacturers, over pharmacies, and over employers, over payers, and over patients. So that's why it's become such a hot topic, because they have so much control in the industry.
Senator Grassley, are these PBM operators, are they subject to any regulation?
Not enough.
Not enough.
Not enough.
Please say a little more.
I've had correspondence with the Federal Trade Commission trying to get them interested in investigation. They're a big part of the Grassley-Wyden effort to reduce prescription drugs. The major problem is that everything about them is opaque. And you've heard me say many times on many different programs of the government, transparency brings accountability. We don't have accountability from the PBMs because there's nothing transparent about them. So just getting how they do their business, so we know who benefits from them, whether it's the pharmaceutical companies, the PBMs, or the consumers, or the pharmacy itself. We don't know any of that, and there's a lot of money involved. So my effort is to bring transparency. Now, maybe that's not exactly regulation, and I said there's not enough regulation, but I'm going to start out with trying to just get everything about PBMs made public and see what that accomplishes.
Now, Dr. Peters, do you have any involvement with this world of PBMs as a practicing physician?
Not much as a practicing physician. I'm a knife doctor, not an herb doctor, but I've been following PBMs for quite a while, keyed in by some pharmacist friends several years ago, and I've been following what's transpired in Montana beginning, I think it was 2014, 2015, where they pushed back on PBMs as well as insurance companies for payments for their state employees, and it's been very effective. And recently, I believe last year, they passed a transparency law in Montana, probably something similar to what Senator Grassley mentioned. And I do agree it's a good first step. I like what the, I can't remember his title, maybe the state auditor in Montana said that we're not sure if this is going to be enough, but at the end of a couple of years, we'll at least know what we need to do next. So transparency is a good start. I think we may need more than that.
Thank you. Who owns these PBMs? Let's see, Brett, can you shed any light on that?
Yeah, and so there's 3 large PBMs in the country, and they are, like I said, they're vertically integrated. So you have PBMs that also are in the same company as health insurers, which own their own specialty pharmacies, own their own some brick and mortar pharmacies, and they're trying to control everything in the healthcare ecosystem. So you're talking about companies like United Healthcare, CVS Caremark, Express Scripts. They're very, very large corporations.
And Senator Grassley, I know you had hearings a while back in this murky world of PBMs. Did any of those representatives come and testify at your committee?
I think we had one that came, but we didn't get the information we need because I've spelled out what I need to hear from the pharmacy benefit managers, just who benefits from that and to what extent do they benefit. And there's a real feeling they benefit the most of any of the 3 or 4 parts of the delivery of pills from manufacturers to the consumers.
I went to the association website earlier today for PBMs, and they talk about they're providing a quality to the healthcare delivery system, ensuring that pharmacies are doing everything correct. Brett, are they providing a service to your members, the Pharmacy Association?
Likely not the way that they describe it. I do think there are some mechanics that do help as far as making the benefits seamless and real time at the pharmacy. But in a lot of ways, PBMs have become impediments to practice. And I think that's, Dr. Peters and other physician colleagues can talk about the way that PBMs try to control the drug therapies that are used and in that manner. And they do control the way that we care for our patients. And so another piece is, they say that they'll lower costs. Just don't ask them how. It gets to what Senator Grassley said. It is, they claim to lower costs, but really, whenever you try to probe deeper and ask questions, you can't get anywhere. And so that's what a lot of these efforts have been around, is providing transparency and shedding light on a broken system.
Okay. Senator Grassley, your proposed legislation, what type of information would be required to be provided?
Well, most of it would be just every part of their operation. We need to know what their profit is. We need to know the arrangements they make with pharmacists. We need to know their connection to the pharmaceutical company. If there's any involvement with the insurance companies, we need to know that. Since so much of the taxpayers' money goes for pharmaceuticals, it seems to me like this is a situation like the public's business ought to be public, because the federal government's the #1 purchaser of drugs.
So as an example, if you don't mind, I'll just go into it a little bit. So a PBM will contract with a given drug company for a rebate on particular medications. They are supposed to, in theory, pass those rebate savings on to pharmaceutical companies, and that would reduce costs for the consumer. What happens oftentimes, however, is that the pharmacy benefits managers pocket some of that rebate, and not as much of that gets passed on. And pharmaceutical companies know this happens. They typically will go along with it because in the process their pharmaceutical may get boosted higher on the formulary for pharmacies, so they're more likely to be dispensed. This gets to kind of the heart of one of the big problems in healthcare is that with the exception of people who are actually paying the bills, nobody really cares about costs because they can always pass it along to someone else, the insurance company, the employer, the federal government, et cetera.
Now, you mentioned a term of art, formulary. Is that a list of medications that are covered under Medicare? And if you're on that list, you have better chance of Medicare paying for it?
Well, not just Medicare, also, and mostly I think we're concerned here about commercial PBMs. It looks like from what I've read that the PBMs that work for Medicare and Medicaid are at least a little bit more responsible than what we're seeing in the private pay sector. But yes, they determine what medications are be available for a given patient depending upon their insurance plan.
And who determines whether a medication is on the list?
I'm going to defer to our pharmacist, but I have a snide answer, but
we can come back to that. Brett, take it away, please.
A lot of times it is the PBM that decides what's on the list. Sometimes there are what they call P&T committees that are embedded in the insurance company themselves. But in many cases, it is the PBM. And like Dr. Peters mentioned, a lot of the times it's financially driven based on what types of rebates they're able to demand at a manufacturer. So they'll tell a manufacturer, you can only sell your drug on our formulary if you give us these large rebates. And so it puts the manufacturers in a really bad bind on the rebate end of the spectrum. And then the other end of the spectrum, they do the same things to pharmacies. If you want access to their members, which, like I said, there's only 3 companies that control almost every prescription in the U.S., you have to take their terms, and there's zero negotiation that goes into those contracts on the pharmacy side.
These rebates, some people call them simply a legalized form of a bribe in order to get my drug on the preferred list. Is that an area of concern to you, these paybacks, these incentives?
It is very much a concern. It's part of that we don't know the complete picture. We just know that it exists. We ought to know how much it exists. And if we knew those informations, I could give you a more definite answer. But I see this whole game of the PBMs finding an excuse to raise their income, and that causes the pharmaceutical companies to raise their price. And I see a ratcheting effect that's more of a concern to me than just the whether it's a bribe or incentive or whatever you want to call it.
And Brett, who pockets these incentives?
Yeah, and that's where a lot of it's murky. So we know not all of it goes back to the employers or the plan sponsors, like in a lot of cases should be. You know, they say rebates should buy down premium, and if that's the case, making it lower cost for consumers, that could be a good thing. But the PBMs themselves do keep cuts of the rebates, and that's what you'll find is they keep a cut of everything they touch. And you know, that's a large part of the problem, is how much they keep. And then the other piece of the problem is you hear about list prices and the list price of drugs skyrocketing. And that's because more and more of that list price is made up of rebate. And so you look at drugs like insulin, which is in the news all the time, the majority of that insulin price tag is actually rebate. And so patients who are uninsured get hurt the most because they don't have the ability to benefit from that rebate at all. And they don't have any sort of copay structure. So they're paying closer to that list price. And so, you know, that's an ultimate concern of mine as well, is PBMs are incentivized to have those drug prices be higher the way that the incentives are in the system. If you make a percentage cut of something, the higher the raw number, the more you get to keep because the raw dollars come in higher.
There's another word that comes up in this arena, and that's the direct and indirect reimbursements. Is that an area, Brett, you would speak to?
Yeah, I can speak to that a little bit, and then I know that's something that the senator is well versed on with his bills as well. So direct and indirect remuneration means that's money that the PBMs take directly out of pharmacies. And it's in the cases of hundreds of thousands of dollars for some pharmacies for single PBMs. It's massive amounts of money. It's gone from just small numbers 8 or 10 years ago to huge amounts of money that are taken back from pharmacies. And they're often taken back months and months down the road. You can't plan for it. A pharmacy's already made their payroll, they've closed their books, and then these big clawbacks happen. They're large amounts of money. They cost more than a lot of cases the staffing at the pharmacies, even on that magnitude. And it's something that started really in the Medicare Part D space, and that's where it's the most problematic. So it is something that we're hopeful with some champions out there in Washington, D.C., we can get a fix for.
Senator,
my legislation that I call Grassley-Wyden would do away with DIRs. It would just eliminate it. In other words, and Brett, you can correct me on this, but the way I see it, sometime at the beginning of a year or sometimes over some period of time, they make some sort of a contract with PBMs and the local pharmacists. And then at the end of the year, something on that contract isn't delivered. And then they get a bill for sometimes tens of thousands of dollars. And this is just wrong. And we just simply do away with the clawback.
Okay. Dr. Peters, anything to you want to add on this clawback subject?
I do. This has been something that's been brought to my attention by local pharmacists, particularly ones that are privately owned. Senator Grassley, if you haven't met John and Jay Nicholson of Mahaska Drug in Oskaloosa, I highly recommend you pay them a visit. They'd be thrilled to show you reams and reams of paperwork about how their pharmacy has been adversely affected. And it's been a few years since I looked at the data, but I know that we've lost quite a few private pharmacies in Iowa, at least part because of the adverse financial effect of these reimbursement problems that we've just gone over, the clawbacks, et cetera.
And to Dr. Peters' point, we've lost more than 50 pharmacies in the last 2 years in Iowa, largely driven by PBMs.
Thank you for that clarification. I didn't know the number. Thank you. Well, and Brett, that's a pharmacy that's getting a clawback months after they've sold the medication?
Yeah, and that happens in all spaces, Medicare Part D and commercial spaces, there are clawbacks. So we have a bill that's in the state legislature that the House passed unanimously that does have provisions to eliminate clawbacks. And like you heard, there's a bill out in the United States Senate to do the same thing on the Medicare side.
Okay. I don't know if Senator Grassley is familiar with that proposal, but if you are, sir, is there any likelihood of that getting passed?
You're talking about what I call the Grassley-Wyden bill and the provisions.
Okay. Yes.
It's kind of a political answer. The way Congress is made up today, there's one way of handling the price of drugs, and then there's the Grassley-Wyden bill. And until there's a conclusion that the other approach won't work, I've got the one that has a bipartisan answer, and it could easily get 60 votes in the United States Senate, but things haven't come around to that point of view. But I still work the bill every year. I could give you a long list of both private and group conversations I have with members of the House and members of the Senate on that subject, but I don't think you're interested in that. But I don't sit around and wait for the other group to come to the conclusion that they can't pass their bill and that they ought to move in my direction, but I'm always talking about it.
Fair enough. Now, some people are confused, Brett, about the difference between a clawback and the incentive that are being paid. Can you shed some more light on that?
Yeah, I'll see if I can answer your question. So so the clawbacks are generally what we refer to when money passes from a pharmacy to a PBM. And oftentimes, some of that even comes out of patient copays, which I find the most egregious. If a patient goes to the pharmacy and pays $50, they expect that to remain at the pharmacy, when sometimes a large portion of that could go back to the PBM out of their pocket. So, that's one problem with that. As far as incentives go, I'm not exactly clear what you're referring to, but Senator Grassley did mention how sometimes the Medicare space will say that they base these fees off of quality measures. And what we've found is there are pharmacies that will score in the 99th percentile on their quality measures and still have massive DIR clawbacks taken out of them. So they are really not quality based at all.
And it suggests that it's arbitrary and no uniformity in how they review these so-called quality control measures.
Yeah, and one problem is pharmacies don't even know the magnitude of these fees. A lot of them can't tell you for sure how much they even pay in total in the fees, because it's so murky. It's not reported in a transparent manner, and it's really hard to get your arms around the true magnitude of that.
Okay.
I want to make clear that Grassley-Wyden will standardize quality measures.
So when it would no longer permit arbitrary, inconsistent approaches to a particular pharmacy. There'd have to be some uniform standards.
You have correctly spelled out the motivations behind my legislation.
Very good. We've heard a little bit about the federal level. Brett, can you share any thoughts on what's taking place in the states and particularly in Iowa?
Yeah, that's something that states have been working on for quite a while, actually. About 10 years ago, Iowa passed a pretty good PBM bill. It got caught up in the courts. Arkansas also passed one in that same time frame that got caught up in the courts. The Arkansas bill was actually taken all the way to the United States Supreme Court. It was called the Rutledge case. That was decided unanimously in favor of states being able to regulate pharmacy benefits managers. And so, as your viewers know, the Supreme Court doesn't do a lot on a unanimous basis. And so it was a pretty strong ruling in pharmacy's favor. And so what we've seen is states across the country moving forward pursuant to that decision. We have a really good bill that's in the state legislature here in Iowa right now. It passed the House unanimously. It passed the Senate Commerce Committee unanimously. And we're hoping to get it to the floor of the Senate before they adjourn. It does a lot of the things we've talked about. It eliminates clawbacks. It has a bunch of patient protections. It helps pharmacies that are paid below their cost appeal that so that they get paid what it costs them to purchase the drug. It has provisions that allow Iowans to choose Iowa pharmacy providers because, like I mentioned, with the vertical integration, these companies are mandating that Iowans send their prescriptions out of state. And so, you have patients who are navigating things through the mail. They have the relationships with local pharmacists that they can't take advantage of. And it's mostly so that those companies can, have their cake and eat it too. They're double dipping. They're taking the money as a PBM. They also want the dispensing revenue as well.
And I'd just say that, this is not just a federal issue or an Iowa issue. I last count, there were 41, I think, states which have passed or are in the process of looking at similar legislation to what Brett and Senator Grassley have mentioned. So, and I know PBM seems like a really deep in the weeds kind of a topic, but it's one that's growing in importance, at least in the awareness of legislators, and increasingly more so in the public eye as well. And it's not that middlemen are necessarily bad into themselves, but at least they need to have make their business practices transparent so we can have oversight.
On the cost of medication, one area that comes up and is criticized by some is the advertising of drug manufacturers directly to consumers. Chris, is that consistent with what the AMA recommends?
I'm not a member of the AMA, so I do not know the answer to that, honestly.
Okay.
Could I speak to that point?
Yes, please.
It's one thing to talk about should they be advertised at all, but within that subject, there's a narrow area that Senator Durbin and I are working on, and it is that a lot of things you see advertised on television, they got a price that they tell you it's going to cost you, but they never say anything about the price of the pharmaceutical. And so Senator Durbin and I one time got through the United States Senate and died in the House. We still introduce this legislation, but we're trying to have that price of that drug advertised on television. We think that when pharmaceutical companies put up their drug to tell you how great it is, and then down in the bottom, they tell you all the things that may cause you problems, reaction, and all that stuff. Surely they ought to be telling you what it's going to cost you. Now, the pharmaceutical companies really fight that, but I think that sort of transparency is very important. If you got on the windshield or the window of your car the cost of that automobile, why shouldn't you know what the cost of the drug is?
Okay. One area that comes up is the difference between what Medicare pays for a drug versus what Medicaid may pay. Brett, can you shed any light on the difference between the reimbursement levels?
Yeah, a little bit. So Medicare Part D would govern what's in the Medicare space, and then that is not entirely consistent. It's done more like traditional PBMs. In Medicaid space, we do have a more transparent model in Iowa that works very, very well. The state pays the average cost of acquisition for the drug and the average cost of dispensing based on a survey that's done of all Iowa pharmacies. So in the Medicaid space in Iowa, we actually have a pretty good model.
Okay. Senator, are there any structural changes that you would recommend or you are proposing as far as the difference between what Medicare and Medicaid pays for the same drug?
Well, I think that we answered part of your question, and I'm not saying it shouldn't be answered further since we first passed Part D of Medicare in 2003. But we wanted to make sure that we had plenty of plans so people could choose a plan that fit them. And then within that plan, people would have choice and a maximum amount of formulary. Now, not every plan has the same formulary, so there's plenty of choice for the consumer on Part D Medicare. And then we wanted the marketplace to make some decision on choice, quality, and price.
Gentlemen, thank you very much for joining us today on an area very challenging that affects all of us. Your participation has been most appreciated.
Thank you.
Thank you.
Thank you.